a real pleasure being here. And my task will be to look at COVID and diabetes from the eye of anti-hyperglycemic medications. So I will discuss a few cases, not really rocket science, but certain few simple cases in the management of diabetes. Here's the first case, a 55-year-old lady who has been recently diagnosed with COVID, and she already has diabetes. She's on metformin, empagliflozin, and dulaglutide. The primary care physician has already started dexamethasone and favipiravir. I'm not an expert on favipiravir, for example, but this was what was started by the primary care physician. And her random blood glucose is 157. The urine ketones are 3+. She's stable, but has high-grade fever and severe fatigue. Now, let's look at how you would manage this lady with all these problems. Especially, let's look at the role of whether to continue metformin, empagliflozin, and dulaglutide, and what the guidelines say. So whenever there is metformin in the background of symptomatic COVID, of course, in asymptomatic people or mildly symptomatic people, you would continue all drugs. But in symptomatic patients, of course, if they're hospitalized, they'll require insulin, but this patient is being managed at home. But even at home, if this patient is symptomatic, there is a risk of dehydration and lactic acidosis in patients on metformin. So it's better to stop metformin in this lady. And also during illness, it's important to monitor the renal functions because of the high risk of lactic acidosis and kidney failure, worsening lactic acidosis due to metformin. Let's look at the second drug this lady is on, and she's on empagliflozin. And there are several SGLT2 inhibitors, and this is a position statement, a recommendation statement published in the Lancet Diabetes Endocrinology Journal this year. And the guidelines say that because of the risk of dehydration and diabetic ketoacidosis during illness, symptomatic patients should actually stop taking these drugs and follow sick day rules. And during a respiratory illness, it is important not to initiate therapy with SGLT2 inhibitors in a patient who has got COVID. And renal function should be very carefully monitored for any acute kidney injury. Let's look at the third drug our patient is on, which is dulaglutide. And there are several GLP-1 receptor agonists: albiglutide, dulaglutide, exenatide, liraglutide, lixisenatide, semaglutide. But all these drugs decrease food intake by suppressing appetite. So when food and water intake are reduced, this dehydration is likely to lead to a serious illness. In addition, they often have nausea and vomiting, and adequate fluid intake and regular meals should be encouraged. So we've looked at this patient. Let's come back to this lady, a 55-year-old lady with diabetes on empagliflozin, dulaglutide, and metformin. So the primary care physician has started dexamethasone and favipiravir. So ideally for this patient, it's better because she's symptomatic. The urine ketones are 3+. She has severe fatigue and high fever. It's better to stop empagliflozin, stop dulaglutide, stop metformin, adequate fluid intake. Of course, ideally, if this patient is unwell, would require hospitalization, but a lot of ground realities have to be taken into consideration here. So this patient was started on basal bolus insulin and ketone monitoring at home, and it's better to manage such people symptomatically with basal bolus insulin for glucose control. Now, this is a second case, a 44-year-old lady with diabetes as well as rheumatoid arthritis. She's also on metformin, sitagliptin, and hydroxychloroquine. As you all know, in India, hydroxychloroquine is approved both for rheumatoid arthritis and diabetes, and she's doing well. And she's asking you, she's worried about COVID and what to do. What should you tell her? So this may sound a little controversial, but this is the publication in the Indian Journal of Medical Research in 2020, where they looked at hydroxychloroquine prophylaxis for healthcare workers. So in this study, what they found is that if you look at the x-axis, you have no hydroxychloroquine, hydroxychloroquine without maintenance, 2 to 3 doses, 4 to 5 doses, and 6 doses. And you will see that the trend for a proportion becoming positive for SARS-CoV-2 is actually coming down with higher number of doses of hydroxychloroquine. So consumption of 4 or more maintenance dose of hydroxychloroquine was associated with a significant decline in the odds of getting infected. And here are all the other factors. Just to remember that it's not about hydroxychloroquine, it's about other factors such as people who have never used PPE had a very high risk. People who performed aerosol procedures like endotracheal intubation again had a higher risk. What is interesting is as the number of doses of hydroxychloroquine went up, there was a significant reduction in the odds, and that was statistically significant. In fact, as you see, there's a slight increase in the proportion initially, which keeps coming down. Now, I don't want this to sound as if hydroxychloroquine is effective or hydroxychloroquine is effective as prophylaxis. I'm not taking a stand on hydroxychloroquine here, but just to mention that it is currently approved by the Indian government for the management of diabetes. A study published by the ICMR had shown benefit in COVID-19 prophylaxis. Of course, this study had limitations, an important one being that it was not a randomized study, it was a case control kind of design. So it's important to watch this space. Probably safe to continue the drug for diabetes and rheumatoid arthritis in this setting. So the other drug this patient was on, if you remember, is not just hydroxychloroquine, it is metformin, which I already discussed, and sitagliptin. Now, the good point about dipeptidyl peptidase 4 inhibitors is that they are quite safe, well tolerated, and can be continued in asymptomatic or even mildly symptomatic patients at home. So vildagliptin, alogliptin, linagliptin, saxagliptin, sitagliptin can all be continued. They are safe. The important point is that I've seen a lot of slides where they suggest that DPP4 inhibitors would have protection. Well, there's no evidence of protection. There are some hypotheses which are published, but there's no evidence of their protection. What about sulfonylurea and pioglitazone? I think it's important to that sulfonylureas are safe and pioglitazone is safe. Continue in mild cases. Watch for hypoglycemia with sulfonylurea, but we know that COVID affects the lungs, and that can also cause some lung changes, and heart failure, which can be precipitated with pioglitazone, may also be picked up as some opacities in the lungs. This point is very important to remember, and therefore, friends, I think we should remember this clinical point and be careful with pioglitazone. I probably would not continue it, but I rarely prescribe pioglitazone in my practice. Watch out for hypoglycemia with sulfonylurea. So, insulin therapy. Number one, insulin therapy should not be stopped. That's what the guidelines say. Number 2 point is that regular self-monitoring of blood glucose every 2 to 4 hours should be encouraged. Sometimes there may be role for CGM as well in type 1 diabetes, for example. And you need to adjust regular therapy to reach goals. And it's important that insulin is the treatment of choice. Whenever you are in doubt in a patient with COVID and diabetes, I think insulin should be the treatment of choice, and let there be no doubt about it. So coming back to this lady, a 44-year-old lady, she's got type 2 diabetes and rheumatoid arthritis. She's on metformin, sitagliptin, and hydroxychloroquine, doing well, worried about COVID-19. Well, I tell her that since she's doing well, glucose is under control. There are studies to show that people whose blood glucose is under control do very well, do better than people whose blood glucose are not under control. I'd reassure her, continue the same medicines. Of course, she needs to be, since she's on hydroxychloroquine for rheumatoid arthritis as well as for diabetes, I think the retina needs to be assessed regularly. Let's look at a third case. Now, this is a third case, a 44-year-old lady. She has had normal blood glucose levels prior to COVID-19. And she had upper respiratory infection. She was diagnosed to have COVID-19 and she recovered. No steroids were prescribed during the COVID-19, but after the COVID-19, uh, she was she develops very symptomatic diabetes. No steroids were prescribed, so this is a new onset diabetes happening after COVID-19, and I've seen a couple of such people, and this is post-COVID-19 diabetes. Her fasting is 145, postprandial is 259, HbA1c is 8.1%. What should the line of management be? There's no real evidence out here, but I'd just like to talk about it. Now, previous research has shown that ACE2, the protein that binds to the SARS-CoV-2, allowing the virus to enter human cells. Now, this ACE2 is located not only in the lungs, but also in other organs and tissues involved in glucose metabolism. In fact, ACE2 is also present in the pancreas, fat tissue, the liver, and the kidney. So people hypothesize that, researchers hypothesize that SARS-CoV virus by binding to ACE2 may cause a complex and heterogeneous dysfunction of glucose metabolism. It may not be that the SARS-CoV virus is binding to ACE2 in the pancreas and causing beta cell failure. No, it may be a multifactorial effect. It may be the ACE2 on several organs. It may be the stress of infection. It may be the lack of lifestyle. It may be other factors, unknown factors as well. So this could explain, and there's a study, that multi-center study that started, which is researching new onset diabetes after COVID-19. And this is some very interesting and important Indian data published from New Delhi, which looks at diabetic ketoacidosis precipitated by COVID. Now, these are case studies, but nevertheless, these are important case studies. The first patient, these are the CT scan and the X-ray pictures of these patients. First was a 30-year-old male, undiagnosed diabetes. Remember, this may or may not be new onset diabetes, but COVID-19 precipitated diabetic ketoacidosis and pneumonia. The second patient was a 60-year-old gentleman, long duration hypertension, but no prior history of diabetes, developed a stroke. And he was also diagnosed with COVID-19 and diabetic ketoacidosis. Both patients responded well to treatment and were discharged in a stable condition. So there are some case reports of possibly type 1 diabetes unmasked because of COVID, and type 2 diabetes because of COVID, resulting in diabetic ketoacidosis. And these are all the case studies, case reports presented across the world. As you see, there have been several such reporting cases. Most of these patients are reporting with symptoms. Of course, this gentleman in the current study from Delhi reported with a stroke. Initial random blood glucose has been very high in some of these patients. The HbA1c also has been uniformly above 9 in all these people. Now, 2 of these people did not have comorbidities, whereas others did have some comorbidities, and some of these patients improved and some of them did not. Notably, the 2 diabetic ketoacidosis people reported from Delhi actually improved. So coming back to this case Vignette number 3, a 44-year-old lady, normal blood glucose levels pre-COVID, now develops symptomatic diabetes. She's completely stable. The COVID-19 has settled, but HbA1c is high. Urine ketones and plasma ketones are all negative. This looks like a type 2 diabetes. Maybe the stress of a COVID infection could have precipitated it, but it could be a new onset diabetes. So in this patient, I would like to manage her just like for any other type 2 diabetes. I would like to manage her with lifestyle modifications and metformin, maybe a DPP-4 inhibitor, and then I'd like to see if lifestyle modifications and the stress levels coming down could help her recover from the COVID infection. Now, this is my final case, and this is a 33-year-old lady who presented with hyperglycemia in pregnancy detected at 25 weeks of gestation. So this is gestational diabetes. This was a first successful, this is part of a case series which we have just published, which looks at telemedicine for the initial management of newly diagnosed gestational diabetes in the pandemic period. We just published this paper a few days ago. So this is a 33-year-old lady. She had several failed intrauterine inseminations and in vitro fertilizations. She has a family history of diabetes, and now her fasting was 93, and the post meals were also high, and she was referred to us for further management. And she did not want to visit a hospital, and therefore she opted for a telemedicine consultation. So if you can see her values, these are her values, and these are the average values. Once we asked her to follow lifestyle modifications, we gave her a glucometer, and that glucometer would sync to the mobile phone and be stored, data would be stored in the cloud, which our diabetes educator could also access. What we found is that after the first week, you can see that the post-lunch values were high, and because the post-breakfast values were high, post-lunch were high in the first week, metformin was started at a very low dose of 250 milligrams twice a day. But soon, as you can see, the post-lunch went to higher values. These are the mean values, 158. Mean values are average. So some of these values could be lower. Some of these values were significantly higher. So because of the mean values being high, we increase the metformin from 250 mg twice daily, we increased it to 500 mg twice daily eventually. And then we continued to monitor her, and she eventually delivered a healthy baby. And these are the three cases we followed up during the pandemic, gestational diabetes. These are the average blood glucose levels. Now, the average blood glucose levels includes the preprandial, postprandial, all the levels. And this patient was given lifestyle modifications and metformin. As you can see, case number 3 did very well. Case number 2 is duration of follow-up was only up to 5 weeks. And the case number 1, as I mentioned, continued and did very well up to delivery. Just to highlight that if you look at the UK guidelines, they say that lifestyle modifications, metformin, and then insulin. And of course, if sugars are high, insulin could be offered. Now, in a telemedicine, the FIGO, the US guidelines, and the Federation of International Gynecological and Obstetrics Associations are all given guidelines that pregnant women visiting a hospital, you need to alter the guidelines to suit their convenience, and they are stressed on the need for, wherever possible, antenatal follow-up using telehealth and telemedicine by minimizing the risk of a hospital visit, especially if patient is worried. So I suggest that gestational diabetes is mainly postprandial hyperglycemia, can be managed with diet and lifestyle modifications in many of the cases. Metformin can be added. Of course, insulin also should be added as needed, but this is just to document our pragmatic perspective. Ladies and gentlemen, it has been a pleasure discussing this topic with you. I discussed 4 cases. My first case was a person with diabetes on empagliflozin, dulaglutide, and metformin developing symptomatic coronavirus, in which all these drugs were stopped, ketones were 3+, and insulin was started. The second case was a person doing well for rheumatoid arthritis and diabetes on hydroxychloroquine and sitagliptin and metformin, and the same treatment was continued. I also stressed that whenever a patient has moderate to severe illness or hospitalization, insulin should be given. My third case was a case of post-COVID new onset diabetes. Probably it was a pre-existing diabetes precipitated, but we don't know. This needs further research. This patient was managed like any other diabetes. And my final case was a case of gestational diabetes managed successfully with diet, physical activity, and metformin. And I also showed you the little series, a small series published in a small journal, just sharing my experience on that. So I'm going to stop sharing my screen now.